The sad truth is that heart failure can be deadlier than many cancers. Sometimes we don't give that much preference, or even patients don't treat this disease with that much dedication, and neither sometimes doctors follow this patient properly. So you can understand that the 5 years death rate of heart failure is more than leukemia, colon and rectum cancer, NHL, Hodgkin lymphoma, and breast cancer. So how severe this disease can be? And it is a progressive condition with high mortality. That means even if the patient feels that he is not symptomatic, in fact, the disease is progressing slowly and it leads to problems. And these patients are at high risk of death and hospitalization. And 9 out of 10 patients are symptomatic, even with current heart failure standard of care. And nearly one third of the patient with reduced EF are at high risk of hospitalization or CV death, including those who appear to be stable. And every admission, obviously, it increases the risk of mortality. It's a bigger challenge because all of you know that coronary artery disease comes 10 years early in our country as compared to the Western standards. So that is why the heart failure also is early. So we have a mean age of patient which is 53 years. Hospital mortality also is high in hospital, and post discharge mortality is also quite high. So basically, it's different. It's more aggressive disease in our country. 23% of Indian patients with heart failure, they die within a year of diagnosis. And patients in India and Africa had the highest mortality. In the analysis of cause-specific mortality, we noted that for cardiac death alone, patients in India were at highest hazard of cardiac death. And already you people know that survival rates for heart failure are worse than for most cancers. Heart failure, we all know that first 96 well-HF trial, then consensus, basically which showed the ACE inhibitors. Then well-HF2 came, then SOLVE-T trial, and then AIR trial, basically establishing the role of RAAS system blockage in heart failure. And then came the beta blockers, then one trial of digoxin of DIG trial, and then beta blockers again, carvedilol, Copernicus trial. So over the years, we have good drugs to treat these patients of heart failure. So basically, after that, there are a lot of other things started happening like CRT, ICD, and ivabradine, and then MRA and the antagonists. So then the paradigm HF, and then recently DAPA HF, and Emperor other trials, which showed, there's a lot of changes the way we treat these patients. This paradigm HF was a big step forward, which totally changed the indications, the guidelines. This is the basically ARNI in the patients of heart failure with reduced EF. How a single trial with so much statistical significance basically entered into the guidelines because of the impact it has on these patients, because it was compared with enalapril and it was on the top of standard heart failure with reduced therapy, EF therapy. So basically it had patients of class 2 to class 4, EF less than 35%, and BNP was raised, but exclusion was that GFR less than 30, patient is excluded. Symptomatic hypotension, this is very important, symptomatic hypotension, because in heart failure, many patients will have 100 blood pressure, 95 systolic blood pressure, but they will have no symptoms. So then you can still introduce this therapy because they will still tolerate. And otherwise, you have to stop this. And any current acute decompensated heart failure, history of severe pulmonary disease, and potassium more than 5.2 milligrams. There's no point waiting because 20% of the stable patients in Paradigm HF had a primary event and 17% died during the course of the trial. So-called stable patients. Of stable patients who experienced a primary event, death preceded heart failure hospitalization in 51%, and 60% of these deaths were sudden cardiac deaths. So this is an illusion of stability in heart failure. So ARNI basically should be started as early as possible. Don't wait till deterioration occurs. De novo heart failure is a distinctive type of phenotype from acute decompensation. Basically, in de novo means there is no past history. Usually the comorbidities are not there. Trigger events can be valvular incompetence, cardiac ischemia, and clinical presentation can be cardiogenic shock and acute pulmonary edema. Main pathophysiology is acute hemodynamic derangement caused by LV systolic dysfunction. As compared to ADHF, where patient has dyspnea, orthopnea, edema, ascites, weight gain, and patient has history of comorbidities. Because Paradigm HF did not have this trial, so then there was another trial done for these patients. That was Pioneer HF, basically trial. These were the patients of hospitalization with ADHF, and then they were sort of compared with enalapril and sacubitril, and in hospital initiation blinded study for 8 weeks. And these patients, more important is that these patients should not be on IV vasodilator, IV inotropes, and no increase in IV diuretics in prior 6 hours. This is important. So what they showed is that if you start early clinical benefit in ARNI among patients with reduced EF, what happened basically? That it leads to better control of anti-proBNP, and it also lead to decrease in the CV death or hospitalization for heart failure. So p-value was very significant with a very significant hazard ratio of 0.58. So Pioneer HF basically has again established that you can even start in a patient who is stable, who has ADHF, but he should not be on inotropic support or vasodilators IV. Then this is the right patient to start, and they should have obviously systolic blood pressure more than 100. One more thing which I have learned in my clinical experience is these patients should not be on rising creatinine urea. If rising urea creatinine is there, then you don't start them in the hospital. You wait for the urea creatinine to stabilize. We can start whatever I have already mentioned. So it definitely helps in these patients. So I think this is a consensus that you can start in these patients, but not all patients. That is very, very clear. It lowers the incidence of composite of CV death and hospitalization and even hospitalized patient with reduced EF. So those patients who are previously on ACE inhibitors, you have to ensure that there is a 36 hours off before initiation. And then select the target starting dose, and basically you have to follow with the 50 twice a day, then wait for 1 or 2 weeks and then increase. 200 BD, and if patient is tolerating, then you keep on increasing every 2 weeks. Only thing is monitor the blood pressure, electrolytes, and the renal functions after initiation and after every titration. So if the patients where a RNA administration is not possible, then select the initial dose of ACE inhibitor or ARB, and then every 2 weeks you have to. And evidence-based beta blockers, select initial dose of beta blockers. I think you all know that you have to start beta blockers and start increasing every week. Yes. See, reasons are actually the most common reason is the hypotension. That's what I've seen in my clinical practice. That the patient will start having symptomatic hypotension. That means he will have a lot of weakness, lot of low blood pressure. Patient can have. I think the most common is this only. And second is hyperkalemia, which still can be managed. And target doses, again, symptomatic hypotension. This is the most important cause for. And at that time, important, what is important? Important is that you, when the patients are stable, you should decrease the dose of diuretics in these patients. And another very important thing is that now we are also using SGLT2 inhibitors. So if you are using these two, because these two can be together used, then again you have to understand that you have to balance, because SGLT2 also leads to decrease in the blood pressure. You have to understand. And sometimes the patients are stable, you have to increase their fluid intake, because if they are stable. So patient taking lower than target doses still had a lower risk of primary event compared with those taking lower than target doses of enalapril. So this is very important, that if you are not able to achieve the target dose, which is basically, what they recommend is a 200 BD, then even then whatever you can achieve is a beneficial. So it's a dose dependent effect. The effect will be less than the peak effect, but it will be there. Yes. ARNI reduces the risk of CV death and hospitalization in patient with low blood pressure. Still, it is beneficial. 12% reduction in the risk of CV death or hospitalization in patient with a low systolic blood pressure. So this is again chart showing that those patients who had event rate per 100 patient years, you can see the still hazard ratio is around 0.8, 0.88 and 0.84. So the most important thing is to correct the volume or the salt depletion prior to the administration of sacubitril/valsartan, or start it at a very low dose. And what is more important is the dose of diuretics. If you are giving them maybe every day, this loop diuretics, you can definitely make it every other day. And in fragile patients, better to start with a low dose. And in patients previously on low dose of ACE inhibitor who are naive to this thing, or these naive, then lower starting dose or a slow up titration is recommended. So the important point is starting low, going slow. Should be a standard consideration in the clinical practice, especially in patients prone to hypotension. ARNI, there is a analysis in even paradigm HF also, that introduction of ARNI reduce the need of device therapy. Yes, it has. Recommendation for ICD in patient with a defibrillator. We all know that any patient who has low EF and primary prevention, and if you have optimally managed these patients, if they have acute MI and after 40 days of revascularization, still the EF is less, then and if you think that other organs are all right and the survival is of up to 1 year, this patient will survive anyway, then you need to put ICD in these patients. Yes, 55% of patients who were hospitalized for heart failure had diabetes mellitus. So this is a big chunk of patients who has diabetes. And it has been shown that diabetes is part of the many trials, and prevalence of reduced EF in diabetic patients again is from the tune of 10 to 28% in different trials. And it has reduced dosage of insulin in these patients. New in use of insulin was 29% lower with ARNI than with enalapril. And few patients were started on OHA therapy with ARNI. Because you all know that up to 40% of ADHF patients will be normal EF patients, which is preserved EF. So again, this will help these patients. Yes, the benefits are less in these patients. There are another study and one, I think ESC also study just now in this year only discussed, where they have shown that ARNI is recommended for preserved EF, but the SGLT2 is better in these patients, slightly more better than ARNI in these patients. So you must consider, if you want to consider one drug, it is SGLT2. But if the patient still is not getting much benefit, you should add ARNI in these patients. Most important and fearful is angioedema. Hypotension is the most common side effect. Impaired renal functions, hyperkalemia and cough. Yes, many patients of sacubitril valsartan will have cough, ARNI. I have seen few of my patients also. Because this drug is basically having ARBs. Risk of hyperkalemia again was less with ARNI than if you combine enalapril with MRA. This also was shown in the study paradigm HF. Again, the side effects is basically again because of the hyperkalemia and other things. NSAIDs again lead to risk of renal injury, lithium, birth control pill. They all have effect there. See, there are contraindication means most likely if the kidney function is very bad. So basically GFR less than 20 ml per minute per meter square, because these patients will have compromised renal failure and they will get hyperkalemia, and you will find that the after starting ARNI in these patients, the creatinine start rising more. That's what I've seen. So that is why up to maybe 3.5 creatinine maybe you can use. After that, it becomes dangerous. Low potassium diet, like we manage without ARNI also, basically. And K-bind in emergency situations we have to use. Smaller doses of loop diuretic can be given. Gold is gold because glucose infusion in stubborn cases. So there is a lot of data on patients who are having dilated cardiomyopathy, and they basically improved. So ejection fraction improved. So many people, they sometimes stop the drugs, and even patients also and doctors also. So what happened is that ARNI withdrawal in patient with heart failure and reduced EF was independently associated with increased all-cause mortality. And patients who continued, they showed an improvement in functional class, LVEF and NT-proBNP levels. So I think it is very important to understand that if you remove these drugs, many of the patients can have again go back into the low ejection fraction. In all these three, if you reduce the drug, it can have problems. So all the guidelines, latest guideline also says that in patient with the improved EF after treatment, GDMT, guideline directed medical therapy, should be continued to prevent relapse of heart failure and LV dysfunction, even in patients who may become asymptomatic. ARNI is a molecular sensory and is indispensable and superior to ACE inhibitor in reducing CV death, heart failure, and heart failure for hospitalization and SCD. It improves the EF in reduced EF and reverses the adverse LV remodeling and improves quality of life. It should be initiated as early as possible in patients with ADHF and de novo HF. Heart time, air time is life years. And definitely it should be given for at least 3 to 6 months along with other foundation therapy for ADUF, reduce EF patients. And you must first give this therapy for a long time, 3 to 4 months, 6 months, then only consider ICD and CRT because many patients will improve. ARNI should be used in all patients of preserved EF up to ejection fraction of around 55%. And along with SGLT2 inhibitors, will reduce the heart failure for hospitalization. Okay, thank you.